updates of Vildagliptin, the fourfold advantage of Vildagliptin. So today we'll be talking in the next 15 minutes the relevance of DPP-4 inhibitors in Asian Indians. Vildagliptin as a pioneer gliptin, why it's really the pioneer gliptin, and what it has been, the trailblazer and the group of gliptins. Update on the recent US FDA guidance on CVOT for anti-diabetic drugs, cardiovascular safety data of Vildagliptin, and also we'll be talking a little bit on the newer Vildagliptin 100 mg SR once daily therapy, and of course, summary and conclusion. So we know that there is an increased DPP-4 enzyme activity in non-obese Indian patients with type 2 diabetes. This has been well established, and we know that this increased DPP-4 enzyme activity correlates with various aspects of obesity, like, it can correlate with presence of diabetes, it can correlate with triceps fold thickness, and a lot of variables of obesity. Now we know that there have been so many studies that the efficacy of DPP-4 inhibitors is higher in Asians than non-Asians. This is partly explained by the thrifty phenotype of the Asians, which they're not really obese but have a lot of metabolically unhealthy characteristics with higher DPP-4 enzymes. So the DPP-4 inhibitors work better in Asians than non-Asians, and we know this from a lot of studies and meta-analysis. And Vildagliptin is really the pioneer gliptin. It was the first study demonstrating that DPP-4 inhibition with Vildagliptin increases the GLP-1 analog, which translates as a durable first-line therapy for diabetes. So Vildagliptin as the pioneer gliptin is a durable first-line therapy for early control in diabetes. There is no harmful weight gain or weight loss associated with Vildagliptin, and low risk of hypoglycemia. We have cardiorenal hepatic safety, which I'll be talking about. And also now we can reduce the pill burden with once daily preparation. Now we've spoken about Vildagliptin as a durable therapy for type 2 diabetes, but what about Vildagliptin as a first-line therapy? So what happens when you use Vildagliptin as the first agent in type 2 diabetes? And there have been a lot of trials, the initial trial, test trial, and most recently, the VERIFY trial, which has been in news, because in VERIFY trial, when we used Vildagliptin with metformin, initially, in the first few days of initial monotherapy versus early combination therapy, we reduced the relative risk of treatment failure by a staggering 49%. So you use Vildagliptin with metformin early in the course of the disease, you reduce treatment failure by almost 50%. So this has been proven to be a durable first-line agent in the treatment of type 2 diabetes. So it is a better DPP-4 inhibitor with less hypoglycemic events, which makes it a good therapy even in the elderly or those prone for higher hypoglycemia, has a better HbA1c reduction, and also gives a better time in range to the patient. So when the time in range with Vildagliptin was studied, patients on Vildagliptin spent an additional 13% in time in range. So this translates to a 3-hour increase in time in range when patients were on Vildagliptin compared to other oral anti-diabetic drugs. And Vildagliptin not only increased the time in range, but also did it at the risk of fewer hypoglycemia. So Vildagliptin was associated with good glycemic control and fewer hypoglycemic episodes, and also the weight control was better in Vildagliptin patients. Now, when we talk about any oral anti-diabetic drug, the first thing that we see today is the CV safety. So is this drug safe as with respect to cardiovascular events? So this is a meta-analysis, a huge meta-analysis of about 17,000 patients. And this said that Vildagliptin was not associated with increased risk for adjusted major adverse cardiovascular events compared to the comparator. And it also did not find a increased risk of heart failure. Now, I say heart failure because there's been quite a controversy of DPP-4 inhibitors that can cause heart failure. But we have many studies now which say that sitagliptin or allogliptin or Vildagliptin is not associated with an increased risk of MACE. And based on all these published CV outcome trials, except saxagliptin, all other gliptins can be considered CV safe. So it's not really a class effect, that you say that saxagliptin causes heart failure. So the other agents in this class can also cause heart failure. This is limited to saxagliptin and does not extend to other agents. Now, why are the DPP-4 inhibitors so different from each other? Can the mechanism of action explain this difference in clinical activity of the DPP-4 inhibitors? Now, when we look at vildagliptin versus sitagliptin or even linagliptin, vildagliptin has a substrate enzyme blocker activity to the DPP-4 as compared to the competitive enzyme inhibitor activity of the sitagliptin and even the linagliptin. So this translates to elevated levels of increasing hormones which are maintained for a much longer time. And this translates again to less glycemic variability, more time in range, and also potent blood glucose lowering in our patients. So when vildagliptin was compared to the other gliptins, they produced a significantly meaningful reduction in HbA1c as compared to sitagliptin and linagliptin. They were superior in HbA1c reduction and also in renal safety. Now, we know many of our patients have these comorbidities of diabetic kidney disease, and we are always at a loss of what oral anti-diabetic to give. And now the good news is vildagliptin is approved at all stages of renal insufficiency. So if you have an eGFR of up to 60, you can give the 50 mg BD dosage. But if the GFR is less than 60, you switch to 50 mg once daily dosage. But it can be given in all stages of CKD and can be considered as an effective oral anti-diabetic drug, even in patients with diabetes and CKD. Now, there are so many studies to give us a wealth of clinical evidence with a vast pool of patient data of vildagliptin, comparing the safety, cardio safety, the renal safety, the hepatic safety, and also studies during fasting in patients. So when we look at the recent US FDA update for type 2 diabetes, we know that there are certain stringent criteria, the drugs that need to pass to be approved for patients with diabetes. Now, when we look at any drug, it has to have 4,000 patient years, 1,500 patients exposed to the new drug for 1 year, and 500 patients at least exposed to the patient for 2 years. And we have data with vildagliptin for all of this. And again, the US FDA mandates that at least 500 patients with stage 3 or 4 CKD should be exposed to this drug, at least 600 patients with CV disease, or at least 600 patients older than 65 years of age should be exposed to the new drug before the drug is marketed. And we have enough data with vildagliptin for all of these patient populations. Now, what about long-term cardiovascular outcome trials with DPP-4 inhibitors? Now, we have the T-Course trial with sitagliptin. It met the primary safety objective. Saxagliptin met the primary safety objective, but there was an increased risk of hospitalization for heart failure. We have the Examine for alogliptin, and we have the Carolina, which looked at linagliptin versus glimepiride, and again said that the safety, the long-term cardiovascular safety with DPP-4 inhibitors is good and should not be worried about. So again, I want to emphasize that it's not a class effect, and based on all the published CV outcome trials, except saxagliptin, all other gliptins can be considered CV safe. Now, what about heart failure? There was again no significant difference in risk of heart failure hospitalization with vildagliptin in diabetic patients who had systolic chronic heart failure. And this was a study which looked at the cardiovascular safety of vildagliptin in patients with type 2 diabetes, and it looked at a European multi-database, and it looked to see if vildagliptin was associated with an increased risk of CV events compared to other non-insulin anti-diabetic drugs. And again, you can see the forest plot that vildagliptin was not associated with any risk of CHF or any other major adverse cardiovascular events. Now, DPP-4 inhibitors have been extensively evaluated for their CV safety, and the cumulative evidence has demonstrated good CV safety with respect to major adverse cardiovascular events. And this data is from more than 12 lakh patients, which shows the robustness of these studies. So we are talking about data of lakhs and lakhs of patients which have been studied to come to this clinical conclusion. Now, we've spoken about how good vildagliptin is in the management of type 2 diabetes, be it patients with renal failure or hepatic failure, but we have a need for newer therapies in diabetes management, which will increase the patient compliance and lead to a better adherence, also help in inpatient management, and is also economic and affordable by many of our patients. Now, this should be done without compromising the safety and efficacy of the drug, and this is where the Vildagliptin 100 mg OD dosing comes into picture. So this is a sustained release formulation which provides a quick achievement of a drug plasma level which remains constant at a value within the therapeutic range for a significant period of time. So this assures the control all day long in our patients. It is actually bioequivalent to a BD dosage, and there is a 24-hour control with a 90% inhibition of the DPP4 enzyme. Now, this has a polymer matrix system which avoids the peak to trough fluctuations in the fluctuations of the drug, and it's also not significantly affected by gastric pH and hydrodynamic conditions with fewer side effects. So when the DPP4 inhibition was compared with the standard that we have now, that is the Vildagliptin 50 mg BD dosage was compared. The Vildagliptin sustained release given once a day achieved almost the same percentage of DPP4 inhibition while you're giving the drug BD as compared to while you're giving the drug once daily. So there was no compromise in the DPP4 inhibition, even though you're giving it only once daily. Now, they also compared the Vildagliptin given twice a day compared to Vildagliptin given once a day, and there was no significant difference between the two therapies with regard to HbA1c reduction. It was the same, but then you give it once a day or twice a day. The study also confirmed weight neutrality. So patients who are on once a day Vildagliptin did not gain more weight as compared to BD dosage, and there was also no change in liver enzymes or other safety parameters were also similar between these two groups. So Vildagliptin 100 mg once a day reduced HbA1c in a similar fashion when given once a day as compared to given twice a day. So again, this was a study which looked at Vildagliptin 100 mg OD given, and this was presented at the research retreat recently. And when Vildagliptin 100 mg was added to patients after a week of metformin monotherapy, there was a significant increase in proportion of patients in time in range, and there was also an increasing trend for time in range in patients. So I would like to conclude that, Vildagliptin really stands apart, and what really makes it stand apart is that the plethora of clinical evidence to prove its efficacy and safety, assurance of an earlier and better glycemic control given earlier in the course of type 2 diabetes. You are better off rather than waiting for the patient to have treatment failure. Start it early in your patients as verified by the verified trial. And there are benefits of durability, low hypoglycemia risk, and also no body weight gain. So we are struggling with obesity, which is a major, difficult to treat comorbidity in patients with type 2 diabetes. So this is also weight neutral, offers more opportunities to address individual patient needs, and also improves patients' adherence to treatment, especially in the OD dosing. Thank you for your patience.